Good afternoon, everybody, and I want to welcome every one of you and those online to our Transplant Institute lecture series. Today, we're taking a different spin and for an interesting topic. For those who do not know me, my name is Marwan Albazoud, Director of the Transplant Institute, and it's a privilege to be on that task. Today, we have with us Dr. Ed Perez, a wonderful partner who joined us a few years ago and has made a great impact on the bone marrow transplant program or stem cell transplants. And I think since then, you've gone up, what, 30% in volume or something like that. Dr. Perez has an interest in graft-versus-host disease, and as you see, graft-versus-leukemia, which is an indication for that transplant. He comes to us from the University of Michigan on staff, where he was on staff there, and prior to that, he did his training at Karmanos Cancer Institute. And he's got significant interests, many of which he's has some funding with. And his biggest collaboration, though, and contribution to the program is the expansion of our volumes and the outreach and contributions to upcoming research in this division. And thank you much, Dr. Perez, for agreeing to present.
Of course. Thank you. Thank you. Okay, so today I'm going to talk about graft-versus-host disease, and obviously also the graft-versus-leukemia effect that comes with it. The learning objectives will kind of go through the pathophysiology of graft-versus-host disease, regulators of graft-versus-host disease, the graft-versus-leukemia effect, and then potential targets and treatment of graft-versus-host disease. So allogeneic peripheral blood stem cell transplant continues to expand as a curative therapy for hematological malignancies. It continues to be a vehicle for the generating a potent immunological graft-versus-leukemia effect. The potentially curative therapy for malignant and non-malignant diseases really relies on the chemotherapy conditioning regimen that consists of chemotherapy and radiation, the donor graft, and then the subsequent immunological effects of the graft-versus-leukemia effect with donor T cells. And again, this leads to the curative form of therapy that we use for transplantation, and we try to avoid the graft-versus-host disease. So survival has significantly improved in recent years due to not only improvements in molecular typing in regards to recipient and donor selection, the conditioning regimen over the last 10 years with the advent of reduced intensity conditioning, we are able to offer even older patient population, reduced intensity transplantation, supportive care in regards to infectious complications, newer agents that treat invasive aspergillus and CMV, and what I'm going to spend a lot of time talking about today, graft-versus-host disease prophylaxis. So the safety and effectiveness of allogeneic transplant, again, has improved in recent years. However, graft-versus-host disease and relapse remain the biggest obstacles to the widespread use of this therapeutic modality. There's approximately 6,800 patients that undergo transplantation per year. The majority of these patients will suffer some degree or manifestation of graft-versus-host disease. The types of transplants that I'll be focusing on today are related allogenic transplantation, unrelated transplantation, and that will include cord blood transplantation for a couple slides. All of these transplants require immune suppression. Patients do develop, depending on the graft source, graft-versus-host disease, and again, we hope to harbor the immunological effects of graft-versus-leukemia to keep these patients in remission. Again, there's no contamination of the product since these are donor-type transplants. So kind of going through just to review with you the ins and outs of doing a transplant. So we identify a recipient with a disease, leukemia, lymphoma, liquid tumor. Once we identify a recipient who requires a transplant, we then undergo HLA typing at high resolution, and we try to identify a match. We can identify a sibling match in about 25% of the cases. If the patient has siblings and they're able to donate. We can also at the same time search the World Bank to identify a donor. We prefer, obviously, a 10 out of 10 serologically typed at high-resolution donor at A, B, C, and DRB1 and DQ. Once that donor has been identified, the patient undergoes conditioning chemotherapy. That donor is cleared. They receive, for new mobilization of their stem cells, granulocyte colony-stimulating factor to increase their white cells. We don't typically, for adult transplantations, go into the OR and get bone marrows. On the occasion we do. However, peripheral blood collection is the most common modalities nowadays. While the patient undergoes their conditioning regimen consisting of chemotherapy and radiation to eradicate disease, we harvest those stem cells. They are flown to us or transported. However, in that donor graft, we have to be cognizant of the fact that they contain not only hemopoietic stem cells that are marked by CD34 cells, also there's B cells, antigen-presenting cells, and T cells in the graft. Those cells are then given to the patient. We start immune suppression on day -3. That usually is a backbone of a calcineurin inhibitor and either mini-dose methotrexate or mycophenolate mofetil. We subsequently rely on that graft and the T cells that come with it to harbor that graft-versus-leukemia effect and eradicate any residual disease. Again, we try to avoid graft-versus-host disease. Graft-versus-host disease increases with the type of transplant or the donor source of the graft, with the sibling having about a 35% chance of developing graft-versus-host disease, and an unrelated donor developing graft-versus-host disease in about 60 to 70% of the time. If a patient undergoes a one-antigen mismatch, that increases your rates of graft-versus-host disease to 90%. If you try to decrease your graft-versus-host disease by using a T-cell deplete marrow, depleting T cells either by in vitro or in vivo depletion, you tend to increase your relapse rates. And if you use a syngeneic donor, obviously the rates of relapse will increase because of the lack of recognizing minor or major histocompatibilities.
Where does haplo fall in that? Sorry?
So a haplotransplant about 5 years ago kind of fell at GvHD rates very high and infectious complications. However, with the advent of post-transplant cyclophosphamide, those rates of GvHD remained relatively low nowadays. That's a good question. I didn't add that to the slide, but it's an excellent question. And I guess while we're on the topic in regards to cord blood transplant, I should have actually put those in there as well. So usually if we use either single or double cord blood transplants, which again I'll talk about, the rates of graft-versus-host disease in that transplant kind of mirror the match unrelated donor transplants, about 60% for dual cord blood infusion. Now that's a little different for single cord. However, you have to understand these are multiply mismatched grafts. So that's a 4 out of 6 graft for each dual unit, or a 5 out of 6 for the cords. Those cells are relatively T-cell naive, so the degree or the rates of graft-versus-host disease that they develop are relatively low. Okay. So the most frequent complication following stem cell transplantation is acute GvHD. It's the most common cause of non-relapse mortality. And again, the incidence of graft-versus-host disease, as described, really is dependent on the graft, with the related donor 25 to 40%, matched unrelated donor 50 to 60%, and again the dual cord either 4 out of 6 or 5 out of 6, 40 to 60% chance of developing acute graft-versus-host disease. We really rely on the HLA system in regards to antigen matching, which reduces the risk of graft rejection and graft-versus-host disease in both solid and hemopoietic stem cell transplant. The HLA system is highly pleomorphic and is subdivided into 2 major classes, Class 1, A, B, and C, and Class 2, DR, DQ, and DP. Class 1 presents endogenous peptides to CD8, with Class 2 presenting exogenous amino acids to CD4 cells. High-resolution allelic level type HLA typing has improved the results of related and matched unrelated donor stem cell transplantation. However, even with donor-recipient high-resolution HLA matching at Class 1 and Class 2, the incidence of grades 2 to 4 GvHD in the matched unrelated donor transplantation cohort are still as high as 80%. So kind of comparing solid organ transplantation to hemopoietic stem cell transplants, there's a couple of major differences. For a recipient who's receiving a donor graft, those immune cells come with the transplant. So basically you're ablating the patient's marrow, you're making room for the graft. However, you run the risk of, with these immune cells, activation, which again I'll talk about, and graft-versus-host disease of the recipient organs. Those organs include the liver, skin, and gut. Unlike solid organ transplant, where you have a host immune system present, and then you develop either acute or chronic rejection of the graft from the host immune system, or the recipient's immune system per se. Again, without the development of graft-versus-host disease, we have many patients who do not require immunosuppression lifelong. So at day 50 to 60, we start tapering immune suppression in our patient population, and usually by day 180, without the development of graft-versus-host disease, we stop immune suppression altogether. So these patients do not require lifelong immune suppression. The GvH response is not limited, unfortunately, to the malignant cells, but it also is mediated against host foreign epithelial tissues. So kind of running through the Ferrara wheel here, the chemotherapy and radiation therapy that we give obviously ablates the marrow, but it does cause tissue or host tissue damage, which is classically called the initiation phase. This host tissue damage, especially the GI tract, elicits disrupted mucosa, which elicits this inflammatory cytokines, TNF-alpha, IL-1, and IL-6. These are now kind of called the danger-associated molecular patterns, or the pathogen-associated molecular patterns from the GI tract. This is kind of the newer terminology they're using. These inflammatory cytokines activate host antigen-presenting cells. These host antigen-presenting cells then, with MHC class 2, activate donor T cells. This is the effector phase, or the trafficking and expansion. This leads to interferon gamma and IL-2 secretion that stimulates cytotoxic T lymphocytes and NK cells, which again cause apoptosis of target tissue. The target tissue is again usually the GI, skin, and liver. I will kind of go through these steps kind of step by step here. So phase one, really the transplant conditioning, is really what causes this disruption in this chain. The chemotherapy radiation disrupts the microbiota diversity, the graft-versus-host disease. Once these danger-associated molecular patterns and these pathogen-associated molecular patterns kind of stimulate this inflammatory cascade, these activate the host antigen-presenting cells, causing MHC and co-stimulation. These cells are in very close proximity to the GI mucosa and lymphoid tissue. The class 2 fibroblasts activate the CD4 cells. These CD4 cells are again stimulated by the recipient antigen-presenting cells. They subsequently release IL-12, TGF-beta, and interleukin-6 and TGF-beta can induce the types of T cells, either type 1, type 2, type 17, and then you can have T cell differentiation. Once you have T cell differentiation, that can stimulate your TNF-alpha as well as your interleukin-6, causing cytotoxic T lymphocyte apoptosis and mononuclear cell priming that can again attack the host tissue, either the GI, liver, or skin. Our goal in transplantation is to elicit the immunological effects of the graft-versus-leukemia with avoiding graft-versus-host disease. Unfortunately, again, dependent on the graft source, these rates can be relatively high, and new prophylactic measures to prevent graft-versus-host disease are needed. There's two forms of graft-versus-host disease, either acute or chronic, and they really differ in the time and presentation and the pathophysiology. Today I'll be spending most of my time talking about acute graft-versus-host disease. Graft-versus-host disease in the acute form is really T-cell mediated, and it's again directed against both major and minor histocompatibility antigens. What are the triggers for acute GvHD? Obviously major histocompatibility antigens, so your graft source. Amino acid substitutions have recently been found at certain class 1 and class 2 positions, and class 1 at B and C at positions 99 and 116. These tend to at least trigger increased incidence of graft-versus-host disease in those transplants. Minor histocompatibility antigens. So the Y chromosome encoded antigens, female to male hematopoietic stem cell transplants have a higher incidence of graft-versus-host disease. That's why we have a preferential selection of male donors. TBI in the conditioning regimen seems to increase the incidence of acute graft-versus-host disease, grades 2 to 4. And killer immunoglobulin-like receptors, or KIR ligands, also alter the risk of GvHD. And I will go over those briefly. So when we look at immunologically mismatched grafts, if patients has no mismatches, the overall survival is about 50% at 40 months, compared to a one antigen mismatch or a more than one antigen mismatch graft, where the overall survival can be relatively low, secondary to, again, graft-versus-host disease. If we look at the rates of grades 2 to 4 graft-versus-host disease, with the highest being the multiply mismatched grafts, compared to the 1 and 2 0 mismatched grafts. Again, this is significant graft-versus-host disease, grades 2 to 4, where you do require corticosteroid treatment. I will go over grades 1 and stage 1 disease as well. How about minor histocompatibility antigens, female donor and a male recipient? So this was from Stern in Transplant 2008. He looked at overall survival and transplant-related mortality from a female donor and a male recipient. Transplant-related mortality was increased and overall survival was decreased. Kanuma, in a recent publication in 2014, looked at, again, overall survival in patients who went a female to male recipient transplant, with an impact on overall survival and rates of acute GvHD, grades 2 to 4 years after transplantation. Actually, Dr. Farhan is going to submit this for publication. So here at Henry Ford, we did a gender mismatched transplants versus matched unrelated donors. We did a retrospective analysis in male adult patients transplanted at our center in the last 10 years. N of 56, the donors were female to male recipient in 24 and mismatched MUDs in 32. Follow-up being 8 months. Results were interesting, with the 48% of those patients who underwent a female to male related donor transplant having steroid refractory GvHD in 48% of the time, with 25% of those patients who underwent just a mismatched MUD having steroid refractory GvHD. Killer immunoglobulin-like receptors, or KIR ligand, alters the risk of GvHD. The NK cells are alloreactive in the setting of allogenic transplantation, and this is again determined by the specificity of the KIR immunoglobulin receptors on the donor NK cells. Some of the donors have a subset of these NK cells that do not express inhibitory KIRs that recognize conjugate MHC class 1. If this potential exists, a donor is said to be KIR ligand mismatch. So obviously we would like to harbor the GVL effect of these mismatches without harboring graft-versus-host disease and no NK cell mediated graft-versus-host disease. When we look at transplant outcomes, this was published by Bernstein at Minnesota. For patients undergoing myeloablative transplants, they did not find KIR ligands, and this is cord blood transplants, to be significant. However, those patients who underwent reduced intensity transplantation, grades 3 to 4, graft-versus-host disease were significantly worse in KIR ligand mismatches, as well as transplant-related mortality and overall survival, and all were statistically significant. So what are the target organs for graft-versus-host disease? In grades 1 through 4, it's based on the extent of target organ involvement, the severity of the maculopapular rash, as well as bullet formation. The GI, which results in nausea, emesis, abdominal pain, and diarrhea, and then the liver resulting in hyperbilirubinemia, jaundice, and transaminitis. We stage each organ depending on the degree of skin involvement, with 25% being stage 1, 2, 25 to 50, 3 greater than 50, and if you have bullous formation, grade 3. The GI tract based on the volume of stool, and the liver based on the degree of hyperbilirubinemia. We subsequently, once we have a stage for all organs, we grade them, and then based on the grade, we decide if treatment is needed. So the treatment decision is really based on the severity of symptoms. We usually treat grades 2 to 4 GvHD. Low-grade GvHD in the skin is usually treated with topical, but there is some interesting data that I'll present from Chang, et cetera, which is published in BBMT using TNF blockade early in those patients and their outcome. Systemic therapy is the first line in oral and intravenous corticosteroids. So once we've decided to treat these patients, there's really 3 results, and I'll kind of go over those. So the hope is, with treatment of acute graft-versus-host disease grades 2 to 4, that there will be repair of the damaged organs, there'll be good graft function, and then immune reconstitution as we taper steroids. That's the result we hope for. If the patient responds to steroids up front, there can be some degree of persistent inflammation and what they call relapse or flare of their graft-versus-host disease. They can go on to develop chronic graft-versus-host disease. These patients can develop moderate to severe cytopenias, especially platelet counts. Thrombocytopenia can be significant in those groups who do not respond to steroid therapy. And they go on to develop delayed immune recovery because of the degree of immune suppression they require. If patients progress or become what they call steroid refractory, they have a markedly impaired immune reconstitution and severe cytopenias, and the prognosis is rather dismal. So this is the steroid refractory GvHD with a dismal prognosis. If you do not respond, your prognosis is relatively poor compared to those who, even after CR/PR with steroid refractory disease, respond. So only 50% of the patients will obtain a response to first-line therapy. And we have found some high-risk treatment failure situations, one being hyperacute GvHD or engraftment syndrome, sex mismatch transplantation, and there's recently been published this ST2, which kind of correlates to the resistant to the initial graft-versus-host disease therapy. So looking at patients who develop engraftment syndrome or hyperacute GvHD, kind of what some call it, they looked at this. This was Chang, et cetera, all. Quite a number of patients here, 297, 113 that developed engraftment syndrome, 927 patients, sorry, 808 with no engraftment syndrome. 75% of those who had developed engraftment syndrome went on to develop grades 2 to 4 GvHD. Those in regards to overall survival did poor, 38% versus 54%. Relapse rates were relatively similar, and non-relapse mortality was higher in the patients who developed engraftment syndrome versus those who did not. Also looking at biomarkers, this was done prospectively. They looked at ST2 levels on days 0 and 14. Not that those are days that made a significant difference in regards to the levels, but just those are the days that were collected. Day 0 being the stem cell infusion. Day 14 is when most patients would engraft and develop engraftment syndrome. All levels, ST2, IL-2 receptor alpha, and TNF receptor 1 were significant in those patients who went on to develop engraftment syndrome. ST2 levels, again, this was recently published in the New England Journal in 2013. Panel A shows the mean plasma concentrations of this biomarker receiving myeloablative transplantation day 0, day 14, and day 21. Compared to panel B, which shows patients who underwent reduced intensity conditioning, alive at day 180, measures at day 0, 14, and 21. In multivariate analysis, adjusted for age, disease status, donor source, and HLA match, a high concentration of this marker was significant on day 14, and this was associated with increased risk of death without relapse 6 months after transplant. So what is the rates of graft-versus-host disease? I found this kind of interesting myself after solid organ transplantation. So this is a rare complication after solid organ transplantation. The donor-derived immune cells directed against host tissue. This has been reported in liver, small intestine, and pancreas. It can occur 1 to 11 weeks after transplantation, and there's 2 forms, antibody-mediated in the blood groups, A, B, or AB, and those who receive a solid organ from a blood group donor, O. The second form is cellular mediated. So I have seen a couple cases of this. Usually affects the skin, liver, GI, and bone marrow. And this is very histologically similar as graft-versus-host disease. Donor-derived T cells react with histoincompatibly recipient cells of the organ. Again, the diagnosis is made by histological biopsies. And it's rare in kidney with only 4 cases reported the last time I looked in the literature. So how do we prevent graft-versus-host disease? The backbone of graft-versus-host disease prophylaxis is a calcineurin inhibitor with the combination of mini-dose methotrexate. This is the most common prophylaxis, GvHD prophylaxis, for myeloablative conditioning. In the advent of reduced intensity conditioning or non-myeloablative transplantation and cord blood transplantation, we've substituted the methotrexate with mycophenolate mofetil and a calcineurin inhibitor. There was a recent completion of the BMT-CTN, or Clinical Trials Network, the phase 3 study, which we'll discuss, looking at a calcineurin inhibitor, methotrexate, versus sirolimus and tacrolimus. Again, I will review those results. 2 other ways you can prophylax for GvHD is ex vivo T cell depletion. So historically, there was really an inconsistent reduction in T cells. However, with the advent of magnetic selection beads for CD34 cells, it's been somewhat consistent with the 4 to 5 log reduction in T cells. In vitro T cell depletion is usually with the incorporation of T cell depleting antibodies, such as your Campath ATG, that can again eradicate T cells in the graft. The only thing I wanted to mention in regards to the biomarker concentration at GvHD, so this was data published by Levine in Blood 2012. So this is, again, a prospective study using, it was called Pick the Winner. They used 4 different therapies for graft-versus-host disease. They went back and looked at these biomarkers after the patient was transplanted and after they received therapy for their graft-versus-host disease. They defined these different biomarkers, elephant IL-2 receptor alpha, TNF receptor 1, as being statistically significant for day 180 survival status. They also looked at IL-8 and RAG3. I'll touch on these a little bit later in the talk. They also looked at these biomarker concentrations at GvHD study entry, day 0, and these really did independently predict for day 28 response and day 180 survival in this group of patients. So in regards to GvHD prevention, the calcineurin inhibitor and methotrexate was first described by Storb, and a recent meta-analysis further supports this combination as a very good backbone for GvHD prophylaxis. The calcineurin inhibitor works by T lymphocyte via this nuclear factor activating T cell. It inhibits IL-2 production. The other combination in mycophenolate mofetil, again used in reduced intensity conditioning and cord blood transplants, inhibits inosine monophosphate dehydrogenase. However, the optimal GvHD prophylactic for these 2 modalities yet continues to be studied. So looking at Cutler's data, when they compared this randomized trial, when they used tacrolimus and sirolimus instead of tacrolimus methotrexate, the overall rates of grades 2 to 4 GvHD and survival were very similar. And the cumulative incidence of grades 2 to 4 GvHD in the tacro-sero arm were actually improved. However, the caveat to this study was that in patients who received busulfan conditioning, they developed very high incidence and rates of sinusoidal obstruction syndrome, and those patients actually were taken off study. So the only conditioning that was used, it was TBI based in this study. So what are the novel GvHD prophylactic regimens that have recently been studied? I'll go through 4, and then I'll touch a little bit in regards to TNF blockade in early stage 1 skin GvHD. The combination of the calcineurin inhibitor methotrexate with pentostatin has been studied at the MD Anderson Center in patients going mismatch unrelated donor transplants and match unrelated donor transplants. Bortezomib, which is a proteasome inhibitor, has been studied at the Dana-Farber Center in mismatched unrelated donor transplants, 1 to 2 antigen mismatch. These are very high risk transplants, again with graft-versus-host disease rates of greater than 90%. And then I'll touch a little bit on Marivec in the reduced intensity conditioning setting, and the related and unrelated donors, and then Vorinostat and its use in related reduced intensity conditioning transplantation. So here's kind of the logarithms of these 4 different studies. Patients who underwent transplantation received their calcineurin inhibitor, tacrolimus, starting on day -2. They received mini-dose methotrexate on days 1, 3, and 6. And then they were treated with pentostatins on day plus 18, 15, 22, and 30. And those doses were randomized either 0.5, 1 milligram, 1.5, or 2 milligrams per meter squared. And those patients were all followed for the development of graft-versus-host disease. At the University of Michigan, this was just published, the backbone of tacrolimus and methotrexate with Vorinostat starting on day 0 to day 100. And we'll go through the data on that. And then post-transplant bortezomib with, again, a calcineurin inhibitor and methotrexate. Bortezomib at 1.3 milligrams per meter squared at days 1 + 1, 4, and 7. And that was conducted at the Dana-Farber and Marivec at the University of Pennsylvania, giving the dose 300 milligrams twice a day from day -3 to day plus, I think it was day plus 100 on that one, day plus 10. So in regards to bortezomib, the proteasome inhibitor has immunomodulatory properties. It's kind of interesting. It selectively depletes proliferating alloreactive T lymphocytes, reduces T helper, type 1 cytokines, and blocks antigen-presenting cell activation. Bortezomib may also spare these regulatory T cells, which are important and may be relevant in graft-versus-host disease control. The Dana-Farber added this again at days 1, 4, 7 post-transplant, and again this high-risk population of mismatched transplants in 45 patients who underwent reduced intensity. Day 180 grades 2 to 4 GvHD were only 22%. So again, that compares to rates almost 90% with the transplant-related mortality and non-relapse mortality of almost 50 to 60% in these patient population. This study suggested, again, it's a small n here of only 45, but it did suggest modulation with bortezomib may reduce rates of significantly clinical grades 2 to 4 GvHD in this high-risk population. And again, this is kind of going through this slide set here. Donor chimerism that is established with bortezomib at time points of day 30, 100, and 180. Non-relapse mortality, and again, this high-risk group. And their outcomes of acute graft-versus-host disease grades 2 to 4 being relatively low. Chronic graft-versus-host disease, also for this patient population, is in the range of 90% with only rates of about 38% at 15 months post-transplant. Overall survival was statistically significant compared to matched controls at 2 years, 64% with a 95% confidence interval. And again, looking at the matching in regards to C, there was no statistically significant difference. So moving on to Marivec, this targets T cell trafficking. It uses the chemokine receptor 5 receptor antagonist. It's been studied in phase 1 and phase 2 in 38 patients after reduced intensity transplantation. They use this in combination with Prograf and methotrexate. Grades 2 to 4 graft-versus-host disease in this study were 14 and 23% respectively. Moving on to Vorinostat. This is an inhibitor of the histone deacetylase and was shown to attenuate graft-versus-host disease in preclinical animal models. This study was conducted in 45 patients. It was in combination with standard immunoprophylaxis for GvHD in patients who underwent related donor transplantation. This investigational agent was administered from day -10 to day 100. In 45 study patients, the incidence of day 100 grades 2 to 4 GvHD was significantly lowered compared to controls, 22 versus 42% respectively, being statistically significant. Grades 3 to 4 at day 100 were 4% versus 19% in controls. And the transplant-related mortality at 1 year was 13% versus 19% in controls. This was also reduced. The rates of, or incidence of graft-versus-host disease was globally diminished in all target organs in this study. And then this was presented at ASH, and subsequently the publication just came out. Pentostatin is a purine analog that inhibits adenosine deaminase, leads to increased lymphocyte apoptosis and decreases IL-2 production, which is important in regards to patients who go on to harbor apoptosis of target organs. Preclinical data suggest that this drug induces T lymphocyte function and pairs while sparing natural killer cell hormonal responses. We look at the data in regards to the results. This is again using doses of 0.5, 1 milligram, 1.5, and 2 milligrams per meter squared. In regards to the overall survival, it was statistically significant in the patients who received the 1.5 milligrams per meter squared. Also, the rates of graft-versus-host disease were relatively low compared to controls at the 1.5 milligrams per meter squared dose. Just an interesting study that's also been undertaken for the prophylaxis in high-risk patients is etanercept in combination with extracorporeal photopheresis. This was for reduced intensity patients with unrelated donor transplantation, either being a 1 antigen or 2 antigen mismatch. Again, rates of GvHD higher than 90%, and against non-relapse mortality being relatively high. The combination of tacrolimus starting at day -3 and continuing to day 180 and tapered starting at day 56. Etanercept was given starting at day 0 and continued to day 56 twice a week. And MMF was given from day 0 to day 28. These patients also received ECP, extracorporeal photopheresis, weekly until day 70, and then every other week until day 100, and then after day 100, monthly thereafter until day 180. Agents included the Enbrel and ECP were administered per protocol. The 80 study patients that I last reviewed, the cumulative incidence of day 100 grades 2 to 4 GvHD was significantly lower compared to controls. And overall survival at day 180 was greater than 80% in this high-risk population. This is still being undertaken at the University of Michigan, the follow-up. Lastly, there's been a recent publication looking at the novel treatment of very low-grade skin graft-versus-host disease. This study looked at 34 patients who were enrolled in the study. They received etanercept TNF blockade for stage 1, grade 1 graft-versus-host disease. 14 patients went on to achieve CR, and 10 of those patients went on to have stable disease. This was the algorithm in regards to the intervention. Patients who developed grade 1 acute GvHD of the skin, skins grade 1 to 2 only, received etanercept 2 times a week for 4 weeks. 34 of the patients were enrolled. However, 10 went on to develop, require systemic steroids. 4 week evaluations for graft-versus-host disease were undertaken. Complete response in 14 with stable disease in 10. The patients who developed stable disease went on to continue etanercept, with those that stopped, who developed CR, stopped the etanercept, and each patient went on to have 8-week evaluations for their graft-versus-host disease. So the interesting thing about this study was that patients who received etanercept compared to controls had significantly lower rates of grades 2 to 4 GvHD for those on study, and this lasted up to 12 months. As well as grades 3 to 4 GvHD were almost non-existent in the study population, and chronic GvHD compared to controls was a little bit increased. So just kind of putting all of these agents together, the pentostatin data in regards to, again, these are all low numbers in regards to GvHD in a very high-risk population, seem very beneficial with rates of grades 2 to 4 GvHD of 10%, vorinostat 22 in the match-related donor population, and the high-risk multiply mismatch antigen 1 to 2 antigen mismatch 22% in bortezomib, and Marivac 14.7% for rates of grades 2 to 4 graft-versus-host disease. For a novel agent that have been most recently now in the preclinical as well as some of the clinical models, at least to me, these are kind of all the studies that are going to be undertaken. Some of the intracellular signaling pathways, tyrosine kinase, NF-kappa beta, will be looked at. And again, these are in preclinical animal models currently. I wanted to just touch on cord blood transplantation, just to show you some of the data in regards to acute and chronic GvHD. Again, the modality of cord blood transplantation, they're easy to obtain the graft. These are all at cord blood banks, so there's an ease to access. We can have the cord here in about 14 days or 2 weeks. There's lower than anticipated incidence and severity of graft-versus-host disease in these transplants. And this allows for the expansion of the donor pool, so there's increased representation of ethnic minorities, and we are able to use partially mismatched grafts in this situation. So for ethnic minorities, unlike Caucasians who can find a donor in about 70%, Hispanics can only find a 10 out of 10 donor in about 17% of the time, as well as African Americans only about 20% of the time. Well, they have a 10 out of 10 match. So if you look at rates of grades 2 to 4 GvHD in this patient populations, all transplants, it's relatively similar to match unrelated donors. In patients who undergo myeloablative therapy, cords have a little bit less in regards to graft-versus-host disease, as well as in the non-myeloablative transplants, relatively similar. However, when picking the donor, if you look at time to off immune suppression in the matched unrelated donors versus the cord blood transplant recipients, most of the patients in the cord transplant cohort were off all immune suppression by day 311. This was never reached in the patients who underwent matched unrelated donor transplantation. They stayed on immune suppression, most likely lifelong. How about transplant-related mortality and relapse? Relatively similar in these two groups. Again, you were able to get the patient off immune suppression, which is an added expense, and it immunologically takes a toll on the patient if they stay on immune suppression. So what are we currently doing in regards to our transplant program for looking at graft-versus-host disease? Currently, Dr. Farhan is submitting some of the outcomes on sex mismatch transplants, and that hopefully will be presented at ASH and ASBMT. We're undertaking biomarkers in patients receiving ECP for acute graft-versus-host disease. We finished up in actually this is submitted, the CTN 0502 study, single versus double cord transplantation. This is submitted currently to New England, so the outcomes of graft-versus-host disease in those patients and overall survival. And we currently we've actually engrafted our first patients on the double cord trial using a reduced toxicity conditioning regimen, looking at grades 2 to 4, as well as overall survival. Okay, I think that's it. Yeah. Okay. Any questions? Yes.
What happened, several years ago when I was doing fellowship, the mesenchymal stem cells were very interesting, Osiris.
Yes.
What happened to that?
So the mesenchymal stem cells continue to be studied. However, there has not been a really beneficial effect in the co-infusion of mesenchymal cords as well. The rates of acute GvHD grades 2 to 4 still seem to be somewhat higher in that patient population when the treatment and the prophylaxis. So it has not been a big winner in regards to treatment of acute grades 2 to 4 GvHD, nor prophylactic measures have not seemed to pan out in regards to that therapeutic modality. And it continues to be studied, especially in Europe. I know Carmanos was involved when I was a fellow as well. We were doing quite a few of mesenchymal stem cells in co-infusion. It does support the graft. It seems like it does prevent significant reductions in some of the cytopenias, but in regards to some of the response, they have not been long-lived.
It's in the pathogens of acute GvHD. It's pretty obvious, and recently there was a science paper indicating very clearly that that if you have significant, say, mucositis, there is obviously a higher risk of GvHD. What about, where is the market in terms of, or where is the studies, or what are they thinking about anti-mucositis therapy in combination to prevent GvHD? As this one, are people looking into it? What is?
Yeah, so they looked at palifermin in regards to patients who developed mucositis and acute GvHD. That was published, Dr. Abdi, he actually published that, and it did not seem to significantly decrease rates of acute grades 2 to 4 GvHD. in that study that he published. Initially, that we thought that it would be significantly beneficial, having some degree of endothelial protection as well as GI protection. However, in those patients who did benefit from the prevention of mucositis, that did not seem to delay or decrease the incidence of grades 2 to 4 GvHD in that population. Initially, it was used quite a bit for auto in patients with Melphalan, and then in some of the allotransplant. Those patients also developed significant toxicities in regards to some of their mucosal areas, and as well as some significant angioedema in some of those patients. So there was a group that did have to stop study after they received therapy as well. But that's an interesting question, because you'd think you would, if you protect endothelial damage or prevent endothelial toxicity from your conditioning regimen, would you in turn prevent the inflammatory milieu? And that, again, was thought when we use these reduced intensity conditioning that we would significantly drop rates or decrease rates of acute 2 to 4 GvHD. The rates are still significant, especially in the match unrelated donor population, and even the dual cord transplantation with reduced intensity transplantation. There's significant graft-versus-host disease in those transplants. That's a great question, though.
How does a plasma cell or B cell directed therapy work in this disorder? You mentioned bortezomib.
Mm-hmm. So rituximab, bortezomib, rituximab being a CD20, kind of blocking the B cells, and then bortezomib being proteasome inhibition and having some effect on B cells. So those antigen-presenting cells seem like if they're downregulated, there's less presentation to the donor T cells. However, in the experimental animal models, even with denuded antigen-presenting cells and B cells, those in the animal models at least, they are still able to elicit graft-versus-host disease. So you can eradicate all of them, but even with the significant decrease in the APCs, but it does seem to have some effect on the rates of graft-versus-host disease. There was some retrospective data, I think, by Vorvet, who looked at patients who received rituximab in their conditioning and rates of chronic graft-versus-host disease. Those patients do respond to rituximab about 25 to 30% if we do target their B cells. So it does seem to have some effect for chronic as well as acute graft-versus-host disease.
Okay. It's interesting that you pointed out about engraftment syndrome and the risk for graft-versus-host disease. Generally, just for my knowledge, in terms of presence or absence of acute graft-versus-host disease and the development of chronic graft-versus-host disease, what is the general data? Yeah,
so the majority of patients who develop acute graft-versus-host disease will go on to develop chronic graft-versus-host disease. That incidence has been well studied, so that if you develop acute graft-versus-host disease, it's almost a 90% chance that you will go on to develop at least limited chronic graft-versus-host disease. However, when I say limited chronic graft-versus-host disease, that's mostly just ocular and oral chronic graft-versus-host disease, which is the most common manifestation of chronic. It doesn't mean sclerodermatous, extensive graft-versus-host disease. So you can have grade 2, grade 3 graft-versus-host disease treated, and it really is the spectrum, I think, which in regards to that treatment pedigree that I showed, if you respond and you have all organs that heal, you can still develop chronic graft-versus-host disease at a later date. However, if you go on to have flares of your GvHD, those patients have a higher incidence of chronic graft-versus-host disease. Okay.
When we see patients with GvHD in solid organs, especially liver, quite often we see them advanced. We are very lucky sometimes to have somebody with only bowel manifestations, but typically a lot of them come in advanced and they progress pretty quickly. Knowing your approach on the prevention side and all the drugs, is there any translational strategy to how to handle the solid organs who develop GvHD? Because my experience has been to date that we do not have a very good standardized strategy of how we manage that disease in the solid organs.
Yeah, so I mean, I think again, for doing this for a period of time, corticosteroids being the gold standard, I usually, if there's no response and the patient has multi-organ involvement, I tend to be a little bit more aggressive adding a second agent. I've had very good success using either TNF blockade or extracorporeal photopheresis. TNF blockade works relatively quick. However, the extracorporeal photopheresis does take a little time. But the that strategy in combination, if the data I presented for prophylaxis in those high-risk transplant population, even for treatment, our response rates were in the 50 and 60% range. And those patients tend to tolerate that therapy. Why that therapy? Because it's the least immunosuppressive therapy, the extracorporeal photopheresis, so we can decrease their steroids, we can decrease their other immunological therapies that we're giving them, keep them on that agent, and we're able to increase their Tregs, increase their immune reconstitutions, and their cytopenias. So that's kind of my goal, to use the least immunosuppressive agent, try to reduce the amount of steroids that the patients are on to get them through their graft-versus-host disease, and then any second-line agents that we've used to treat them.
Could we use ECP in the setting?
Yeah, we have used ECP in the setting of solid organ rejection. We have used that. That's what we would typically recommend as an adjunct therapy early on when the patient develops it.
We are not matching for care ligands on a standard basis.
Here we're not. No. Any other?
Well, thank you very much.
Okay, very good. Thank you.